It's 10:30, so let's get underway. Good morning to all of you out there, no matter where you are. I hope that you're safe and that things haven't been too hard. And while we're going through these difficult times with floods and COVID, we've learnt the importance of staying connected to loved ones and to friends. So let's take our minds off these difficult times and let's talk about sex. So we're very pleased that we've got two fantastic presenters, Rhonda and Jocelyn, will join us later. So folks, many of you know me. I'm Joan Hughes, the President of COTA New South Wales, and welcome to today's webinar. I do apologise, there was a couple of miscommunications, but anyway, we're all together now and that's the most important thing. So I'm sure all of you would be very aware of this, but talking about sex, no matter how old you are, especially as a teenager or an older person, it's always been a bit of a taboo in our society. But as we get older, you don't stop being a sexual person, and it's nothing in a sense to do with age. So Jocelyn and Rhonda are going to talk us through what sexuality and intimacy might look like as we get older. So there'll be an opportunity to ask questions through a chat or the Q&A function at the bottom of your screen. Nothing is off limits. I've done one of these before, and the first question was, I thought, oh my goodness, and I had to try and keep my calm, and I did. But it was terrific because people felt like the space was safe and people could ask any questions that were really meaningful to them. So we would like you to do that. Feel free to ask questions, but again, also make them respectful. Before I get started, just excuse me, I have a few technical problems. So I'm actually joining you from the southern coast of just south of Sydney, about 3.5 hours south of Sydney. And we have really poor internet connections. And now with all the rain, other things have happened. So I've lost power this morning and I've lost internet connection. So please be aware of that with me and be a little tolerant if you can't sometimes hear what I'm saying. And if for some reason my internet does go down, then Megan Lawson, our CEO, will come in as the facilitator. But I've got everything crossed, so hopefully. Before we get started, I'd like to acknowledge the traditional custodians of the land that we meet on this morning, and we're meeting from right across New South Wales. I'd like to acknowledge and pay respects to past, present and future elders of this country and their connections to land, sea and community. So for some of you who don't know what we stand for, so it's Council on the Ageing New South Wales, and we are the peak organisation for people over 50 across this wonderful state that's all very wet at the moment. And that means that we are the main policy and advocacy organisation in New South Wales to represent the needs of older people and their interests, but most importantly, to act on what they tell us. So that's what advocacy is all about, to act on the things that are important to older people and make sure that those people who can make decisions, like, should I mention, the governments, policymakers, so we're constantly working with them to try and get a better deal for older people in New South Wales who are over 50. We also work with the media, of course, and that does help to sell our message and to get action from governments. We also provide services for older people, and all of this information is on the website if you want to have a look at the details of things like legal pathways, aged care navigator. It's a very different world out there when you have to start looking at different services for older people. It's a bit of a nightmare. Living Longer, Living Stronger program, which is about exercise for older people. Older Men, New Ideas, and that's another program that we've just sort of secured, which is important. Sometimes we do forget that older men have specific needs that need to be addressed and listened to. And we have a community speakers program, and what that means is we train volunteers who can then come to your organisations, to your communities, often by Zoom now, which is great piece of technology if it works, and they can deliver a whole lot of different information about issues to do with older people, about our services, how to navigate the aged care system and so on. So just a little bit of Zoom housekeeping before we get underway. Everyone, as you know, you're all on mute. So you aren't able to unmute yourself, which is the new word, isn't it, for this, for the last couple of years is, you're on mute, turn it off. Yeah. But all the people out there joining us today, you can't actually unmute yourself. This is a webinar, it's not a meeting. You can ask your own questions though at any time, and by typing them into the Q&A panel at the bottom. So you'll see a Q&A panel, you can start typing questions in there, and the COTA staff will answer them, and I'll use some of those questions to put to Jocelyn and Rhonda as we go through this morning's webinar. You can also upvote someone else's question if you think they're asking something that you'd like to know about. And as I said, we'll be answering those questions during our session this morning. There's also a chat panel at the bottom of your screen where you can make a comment during the presentation. Can you believe, COTA New South Wales, we have a YouTube channel. I think it's so exciting. So this event is being recorded and it will be available from tomorrow. And if you've got friends out there who haven't been able to join us this morning, then they can watch it on COTA New South Wales YouTube channel, along with all our other webinars that we've done last year. And, you know, last year we had so many people respond positively to our webinars, and that's why we've decided to continue them this year. We think they're a great way of connecting people and giving people some information that's important to them at this point in time, or if they're planning things around wills and so on. So we've had a great response, and I want to acknowledge COTA New South Wales staff in making sure that these are a continuing program for older people. So growing older doesn't need to mean, it's the end of your sex life. Many older adults maintain an active, emotionally and physically fulfilling sex life well into their 80s and 90s, and consider physical intimacy with their partners essential to their well-being, especially their emotional health. In today's webinar, we will ask, what does sexuality look like and what does intimacy look like? And is there a difference between those two issues as we get older? Importantly, this discussion will also highlight the importance of sexual health and health sexuality. How do we talk to our health professionals, to our GPs about any concerns we might have? What's the best way to approach this subject that sometimes people find very difficult to talk about? The way in which we are physically intimate with our partners may also change and evolve as we get older. An important discussion is the need for communication and managing sometimes different expectations. For some people with chronic illness, disability, dementia, or other physical limitations, that may also impact older people's sex lives. These limitations can be seen as an opportunity to develop deeper levels of connection. And talking about these issues is probably the first step in trying to have an intimate older life. I look forward to hearing from Rhonda and Jocelyn on these subjects. So that's enough from me. And no, I've still got internet. Whoa, good. So I'm going to introduce Jocelyn Klug first. Jocelyn is an accredited clinical psychosexual therapist. She is the past chair of the Society of Australian Sexologists and has been in private practice for 20 years. And she's currently on sabbatical leave. Jocelyn works with individuals and couples experiencing sexual and relationship difficulties and has a particular interest in sexuality and aging and the impact of chronic illness on sexuality. Jocelyn has presented to a vast range of audiences over her career, and this is what she says about herself. She is sex positive and passionate about the right to choose and enjoy sexual pleasure irrespective of age, gender, or sexual identity. Jocelyn, please join us.
Okay, hold on 1 second. Okay, 1 second. Just need to open up. Am I on? Can you see that?
I can. Yes,
Okay.
lovely.
Hello, everybody, and I'm delighted to be here. Yes, I am a very sex positive person, and obviously I wouldn't be working in this area. I consider the work that I've been doing as a privilege. I get to hear, and over the years, there's not much I haven't heard. And I get to support people by allowing a safe space, obviously, where people are able to, for sometimes, talk about issues that they've never spoken about before. So I like to use a bit of humour when talking about sex. I think that's very good and a nice way to sort of, break the ice a little bit. So this is one of my favourite slides that I've been using for years, and it says, all right, I give up, where's your clitoris? So really, I hope you're having a little bit of a giggle, and people obviously think, well, why doesn't he know? Well, he doesn't know because we can't assume that he knows, and it is our responsibility to communicate what it is that we like sexually from our partners. And of course, I want to normalise the difficulty that many people, most of us, have in talking openly about sex. And the reason for that is we've all grown up in a culture, particularly those of us who are over 50, we've grown up in a culture that hasn't given us a language. It was one of the things we didn't talk about: religion, politics, and sex. Well, that's changing, all for the better. So anyway, I will start.
Sorry, can I just interrupt you? Your slides haven't come up.
Oh, now why is that?
Not sure. Okay. If you go down to share screen.
Let me just get into, and I can't seem to find it on here. So I've got to open up my PowerPoint first. Okay, and then I put that down and go into, I'm not sure. Is that it? Is it up there yet? No.
No. Would you like me to share? I think I have it open, and I think I should be able to share. So I'll share, and just give me a nod when you need me to change slides.
That would be fabulous. Thank you. What's happened here? Hello, Megan, can you hear me?
I can, sorry. Keep talking and I'll get this up as soon as I can.
Okay. All right, so here we go. Are we there?
We are.
Okay. So I just want to go to the next slide, the one I was talking about, to give people a bit of a giggle. That's the one where I was talking about, that we assume our partners know. He's looking for the clitoris. He doesn't know. And it's our responsibility to communicate. We are the experts of our body. And, I know that for many women, they don't understand why their partner doesn't know. The reality is we must not rely on assumptions. Next slide, please. So human sexuality, what is it? It's a sexual interaction. It's a behavioural interaction. It's an emotional and interpersonal interaction. And some people even consider sexuality to be a spiritual one. So anything that affects us in any of these realms will influence sexual and relationship function. Chronic illness can affect each of these realms through changes in our body, image, interaction with our spouse or life partner, feelings of despair or depression. And for some people, chronic illness also has a spiritual aspect to it. And if we could have the next slide, please. So how does chronic illness impact on intimacy and sexual feelings or behaviour in a relationship? Well, first of all, feelings about yourself and your body, particularly sexual feelings, are important to all people. These feelings, and in particular sexual interaction with intimate partners, can be especially challenging for people with chronic illness. A health crisis turns normal people into remarkable people with a remarkable relationship, or it breaks them down and tears their relationship apart. Sometimes turning pain into growth is the only way to salvage something. Illness creates solutions you've never had to face. Resolution of these requires doing things you've never done before or thought you would never do. And the next one, please, Megan. So I want to introduce what we call the good enough sex model. So it's not the perfect sex model, because I don't know what that looks like. A lovely Professor Barry McCarthy in America has come up with this good enough sex model. And it's acknowledging that sex is a good element in your life. It's an invaluable part of an individual and couple's long-term comfort, confidence, intimacy, pleasure, and eroticism. The couple is an intimate team and together promote a vibrant balance of emotional intimacy and eroticism. Sex does not exist in a vacuum, but rather in the context of an intimate relationship. So I'm hoping that these slides might, trigger some questions that you have. So the next one, please, Megan. Thank you. So good enough sex, accurate, realistic, age-appropriate, physiological, psychological, relationship and sexual expectations are essential for sexual satisfaction. Each individual values, respects, and affirms their and their partner's sexual body. Next one. Thank you. So this little one says, and another thing, Francis, all this fuss over same-sex marriage, I just don't see what the big deal is. Harvey and I have been having the same sex for 54 years. And to tell you the truth, it isn't worth getting all upset over. So one of the issues that is often I've come across for older couples is that, sex has become boring, that it's, there's not much in a long-term relationship that you are yet to discover about your partner. But what I've found over the years that for older people in Australia, or in fact the whole world, we each I think struggle with ageism ourselves, and the thinking of that, as you get too old, that sex isn't for you is absolute nonsense. We can enjoy being sexual from the time we're born till the time we die. Next one, thanks, Megan. Okay, so some of the difficulties reported for women around continuing to be sexual. Well, first of all, the most frequent one is a lack of interest in sex. The next one would be painful intercourse. And that can be for a variety of reasons. So if sex is painful, it's not something that you just put up with. Because if we put up with pain, then, through being intimate with our partners, sadly, we become resentful. Feeling anxious about ability to perform sexually. This is both for males and females. I think it's probably more so for males because, in order to get an erection, that's something that's very visual, and anxiety is a huge cause for erectile dysfunction. And I think what's really important here is to remind ourselves that our brain is our biggest sex organ. So people feeling worried during sex about whether their body looks attractive. So of course, as we age and our bodies change, of course, we can all be very, very critical, and, that causes embarrassment and people to, pull back from being intimate with their partners. Next one, thank you. So now, the big sell of the benefits of being sexual. So first of all, sex enhances intimacy with your partner. Now, in saying this, what's really important is to say, if it's not a problem, if your relationship has become asexual, meaning no sexual activity, if that's okay for both people, then it's not a problem. So it's only a problem if it's a problem for one or both. So what we know is regular sex with your partner makes a big difference to how you get along with them. Being intimate with your partner on a frequent basis allows you to emotionally connect with them on a deeper level. We know that sex boosts self-esteem. We feel good about ourselves when we're sexual. We feel, attractive, desired. Sex boosts self-esteem. There is some evidence a lack of sex is associated with feelings of depression and low self-worth. Research supports a positive association between frequency of sex and recall for words in women. So if that's not enough for us to get back into being sexual with our partners, purely because we don't want, we want to be able to, be able to recall and have a good memory. So if sex is good for that, what better reason to be sexual? Sexual activity has also been associated with longevity and general health. In an average sex session, men burn about 100 calories, but women expand only about 70. And we know that sex improves mood, reduces and helps you cope with stress. So when we are sexual, and particularly when we manage to have an orgasm, our brains release endorphins, and these are feel-good hormones. So, you know, sex is good for us. The other reason that being sexual is when we get aroused, blood flows to the genitals, whether it's the vulva, the vagina or the penis. So, you know, regular arousal, we know to be very healthy for us. Okay, next one, please, Megan. Okay, so some of the other difficulties that have been reported, so particularly for men, and this is not just for young men. We seem to think that premature ejaculation or coming to orgasm too quickly is purely an issue for men, but you know, it could sometimes be an issue for women. As we age, of course, physiologically things change, and usually for men, that refractory time between when you've had an orgasm and your ability to have another one actually gets longer. So you're no longer able for a male to have maybe numerous erections and orgasms within a one night, for instance. The other one is, of course, a lack of interest, trouble keeping erections, painful intercourse, and feeling anxious about ability to perform sexually. The next one, please. Thank you. So what impacts on our sexual desire or our libido? Well, stress is a huge one. Anxiety, because when we get anxious, so I'm often explaining this to men, particularly, when we get anxious, our brain releases cortisol and adrenaline. And that means that, your body goes into a fight and flight response. And then what happens is blood flows to your major organs. And sadly for men, that does not include your penis. So when anxiety is there, getting a healthy erection is much more difficulty. Obviously depression, when we're feeling depressed, we know that, the last thing often people feel like doing is being intimate with a partner. But I remember reading a study years ago that said that when people are depressed, sometimes they're, particularly women, more likely to engage in sex, and possibly that's because there's a neediness to be connected. Of course, physical health, and as we age, we all get different ailments. Some people, there are significant changes to their body's ability for movement, so that can come into it. Relationship difficulties, a big one here, and I think looking over the last 2 years and lockdowns and people having less time to pursue their individual pursuits, and it's those things that actually having individual pursuits that you bring back and keep your relationship healthy. So with the restrictions and our inability to go out and live that individual life, particularly through COVID, I think has actually brought about, we know there's an increase in domestic violence. I think there's also an increase in relationship problems. And I know that I'm on sabbatical, but I know my colleagues have been incredibly busy with clients. Erectile dysfunction. So for many reasons, men can experience erectile dysfunction. One of the most common ones with aging is, of course, prostate cancer. And I just want to say that all prostate treatments, whether it's surgical, whether it's using radiotherapy or the seeds or even nerve sparring, that erections will be impacted on, and it's really important that there's a penile rehabilitation program that men take on post-prostatectomy if they want to try and bring back their erections. There's also a lot of different things out there now that are being used to help men post-prostate to get back their erectile dysfunction. One of them, of course, is using the PDE5s, which is Viagra or Cialis. So, there are things available. premature ejaculation, of course, causes huge embarrassment for men, and often what gets in the way there is that, you know, they go to have a sexual encounter with their partner, they're in their head worrying about whether they're going to come too quickly, and of course it becomes a self-fulfilling prophecy. Pain is another one, and of course that gets in the way, and what's really important here is to think about the timing of when you're choosing to be sexually intimate. And, you know, taking analgesia or pain medication, you know, at least for, you know, half an hour to an hour before planning. So planning needs to be, you know, given a greater priority rather than spontaneity as we get older. Another one is medication. And what I've found over the years is we know that many Australians are on antidepressants, the SSRIs in particular. One of the side effects is difficulty in reaching orgasm or difficulty in ejaculating for a male. So it is important that when you are put on new medications to check with the doctor whether they're, you know, what are the potential side effects, and talk to them about it. The many people I've come across over the years have been on antidepressant. Their presenting problem has been that they have difficulty in having an orgasm, and of course you then, you know, of course find out what medication they're taking, and SSRIs, which are the common use antidepressants now, one of their side effects, of course, is that. Next one, please, Megan. Okay, so this is a lovely model of what's getting in the way to us being able to experience pain, you know, pain-free or, you know, good sex, really. So first of all, if you feel that it's a duty, and often it becomes that, particularly for women, I think, in long-term relationships. So if you know, feel that you should be having sex, then of course that then brings on anxiety. Once we get anxious, we get tense. When we're anxious, we're unlikely to become physically aroused. So in a woman, lubricating, in a male, getting an erection. And this is really, you know, what we need to be doing here is, rather than it being a duty, it's something that you're free to make that decision about. When you feel free in making that decision, then you're more likely to feel safe. If you feel safe, you're more likely to feel relaxed. If you're relaxed, you're more likely to be aroused, and that leads to more enjoyable sex. Okay, next one. Thanks, Megan. Okay, so have we just done that? Yeah, we've already done that one. Okay, thank you. So interventions. The first one is, you know, if you're in a relationship, to increase your problem solving skills in order to create alternatives to conventional sexual practices. So that means, you know, it's about thinking outside of the square. Because you can't have an erection, or possibly because intercourse is not possible for the female, it's about looking at what are some of the outer course activities that you can engage in. So part of this is challenging societal, historical, or family messages about sexuality that are detrimental to your sexual health. So as I mentioned previously, one of them is that older people aren't sexual. So it is about challenging that. You know, what were the messages that you got in your family about sex? Now, for most people, our generation, they got no messages. And when, as a young person, you get no messages, I think, about sex, and I think this is obviously because our parents didn't have a language for it. They didn't know how to talk about it because their parents didn't talk to them about it. And I think, you know, what they've found is when parents don't talk about it, young people naturally take it on board that it's not okay to talk about. And hence, you know, we're 50 years down the track and we've still caught up in those messages. So it's about communicating with each other about your illness and identifying steps to enhance sexual pleasure. Practice alternatives to intercourse to achieve sexual satisfaction, and investigate the use of sexual aids, whether it's vibrators, dildos, you know, there's a whole range of different things available now. And I think really important here is to complement each other and affirm the contributions to each other's sexual health. Thank you. The next one, Megan. So this is about giving each other permission to talk about sex, to be anxious, uncertain, and apprehensive, to be unsure of how things are going to turn out. So yes, it's a risk to talk about them, because when we bring up what we might like, there's a chance that we might feel rejected. So it's really important that you feel safe, and that there's an understanding that what one person might like to try, that of course it comes down, like everything, to consent. I think it's important to try out new ways of pleasuring, to modify the plan with your partner, and also for some, choosing not to be sexual. And that's important, that you can do that. To self-pleasure and masturbate. So, I think there's obviously some people still in our generation that see self-pleasuring as something that's not acceptable, but it is seen as a very healthy activity. And let's face it, for many people, aging people, they're either individuals, they're on their own, they've lost a partner, or their partner is no longer in a position to meet your sexual needs. Then it's very healthy to be able to self-pleasure or masturbate. To feel like teenagers again, to giggle about sex. So as I said previously, using humor can be very useful. Use sex toys, and it might be the first time that you've tried this. And there's a whole variety of wonderful sex toys, and there's lots of websites where you can explore that. You don't need to be going into your local sex shop, but I do want to add that that people who work in the sex shops are very informed, and they're not at all embarrassed being able to talk about what might suit you, to try sex in different ways, to explore non-penetrative sex, which is really important. That sex is not just penis in vagina or penetration. That we know that for most women, 80% of women, they are orgasmic through direct clitoral stimulation, which is not about penis in vagina. So to explore turn-ons and what arouses you is important. Next one, thanks, Megan. Consent. So it's the buzzword at the moment. It needs to be. Consent is actually saying yes. It's not assuming. And people can say yes, and then they can say no. And it's okay to change your mind. None of us are obliged. And that's important, that we have that freedom of choice. Next one, thanks, Megan. Okay, so I want to just talk about STIs. There's been an increase in sexually transmitted infections amongst older Australians. It is the shock and horror that you've picked up something. I just want to add that the nicest people can get a sexually transmitted infection. And so, of course, the typical common STI, of course, is herpes, whether it's herpes 1 or 2. And in the past, herpes 1 was like cold sores. That's a herpes simplex virus. And it was oral, and herpes 2 was genital. What's happening now is you can get herpes 1 orally or genitally, and herpes 2 the same. And they are easily spread. And so I'm just encouraging you all that if you are having different sexual partners, that it's important that you actually go and get tested for STIs. Gonorrhea, the rates continue to climb. Syphilis, this was, I couldn't find anything more frequent, but the diagnosis rates highest level recorded was in 2014. And my understanding is it's continued to be the case. Chlamydia is the most frequently reported, but diagnosis rates are on the decline. And I just want to talk about women having sex with women. Apparently 90% of women who have sex with women are also having sex with men. It's just like men who have sex with men, MSM we call that, and they are a particular group themselves, that identify usually as heterosexual, but are out there having different times sex with men. Another one that we need to be careful of is bacterial vaginosis. It's higher amongst women who have sex with women by 20 to 50%. Okay, and the next one, please, Megan. Okay, so, these are just some resources for you that I thought might be useful. And I think that might be the last one, Megan. Yeah, so I just want to talk a little bit about the Society of, we just go back to the previous one, thank you, Society of Australian Sexologists. So that is the main body for accrediting sexuality educators and psychosexual therapists in Australia, because sex therapy is unregulated in Australia, which basically means anyone can put up a shingle and say, I'm a sex therapist. So this is a self-regulating body, and if somebody is accredited, I can assure you that they have met a high standard of both theoretical knowledge, practice, and supervision of their practice. And just the last one, thank you, Megan. So I believe that each of us deserves and has the capacity to live a healthy sexual life, because a healthy sexual life does not mean that your body has to be functioning perfectly. It means, what does having a healthy sexual life mean to each person in a relationship or for you as an individual? Thank you.
Okay, Jocelyn. Well, never too old to learn new information. I found that I'm sitting here writing a whole lot of notes. So thank you so much for your presentation.
My pleasure.
And I think, some important messages which you can probably reinforce when we get into the Q&A session, but the importance of consent. I think, I really liked your slide around that, and it's a very, very important message. And also the idea that that intimacy and having a sexual life doesn't need to be about having sex in the traditional way. There are many ways that we can please our partners, and touching each other and kissing each other and having the cuddles every day. I mean, those sorts of things are very, very important as well. So thank you. I'd now like to, Jocelyn, if you can just go on mute, that would be terrific. And I'd like to introduce Rhonda. Hi, Rhonda.
Good morning.
Good to see you again. So, folks, Rhonda Nay is a emeritus professor at La Trobe University. She's been researching, presenting and publishing on sexuality and ageing and sexuality and dementia since, you ready for this? Since 1987. Good woman. And Rhonda, there was a message that came through from someone, an anonymous question, you might have seen that, about the issues to do with sexuality, intimacy and having dementia. So we're very pleased to hear that that's an area that you have particular interest in. With colleagues, Rhonda has developed the first sexual health policy for aged care, and also a thing called SexAt, and it's an assessment tool for aged care. Her passion is the human rights of older people who are living with dementia. Rhonda, it's great to see you again, and over to you.
Thank you. Thank you. I was saying earlier to this tribe that 3 weeks ago they cut my skull open and took a brain tumor out, and only COTA and sex would bring me out of hiding to actually come talk with you today. So if I lose the plot occasionally, you'll understand why. I think the two main messages that I would like to get across this morning is that we don't want to talk about it, and that there's 100 shades of sex, not 50 shades of grey. And I think that flows on well from what you've just heard, this notion of there's not just one sort of sexuality, there's not one thing we all have to aim for, we're all different, but what is the one thing is that sexuality is important. And I'm going to stress some of the points that you've heard already. If you think about it, we are defined by our sex. I used to say from birth, but now it's from first sight. As soon as parents can actually see whether there's a penis or a vulva, then they start to plan, is it pink, is it blue? It's central to how we walk, how we act, how we relate to people. In fact, I remember years ago reading a study. It was about a fellow who had a sex change operation, And he said that the hardest part of changing was learning how to walk like a woman. So, you know, we are very much defined. It is absolutely, excuse me, central to who we are from when we're little, the sort of toys we're given, the clothes that we're expected to wear, the sports that we played, although this is changing. Certainly for we who are defined as older people, then sport was also very much, you know, boys do this and girls do that. So I think when we talk about sexuality, it is not just genital sex. It is absolutely everything about who we are. And so to then define older people as asexual makes it very easy to define them as non-people, as objects to be ignored. And there have been a lot of studies done on the way in which, as we age, we become invisible. People pass us over in queues. They ignore us when we're trying to get attention in a shop. They tell us that we've dressed inappropriately because, you know, we should all wear those old person's clothes, and I just love defying that. But I have to tell you a story. One of the ones that stuck with me through many, many years. I was giving a presentation in Taree, I think it was, and back then I used to wear shorter skirts, partly because I'm an impatient creature and shorter skirts made it easier to walk, but also to challenge the stereotype that older people, you know, should not wear skirts above the knee. And I finished my presentation and I went out to the loo, and this other woman was out there and she said, you know, you're absolutely right. She said, when you walked in and I saw the length of your skirt, I thought, you are way too young to be a professor. But she said, then I looked at your face and I thought, oh, no, she's not. So I thought, gee, thanks, I'll remember that one. But I think that it is so easy for us to be defined out of sexuality. And why does this happen? It's because of the media. If you think for a moment about what it is that makes you feel sexual, you know, well, for me, it might be hygiene. I need to feel clean. I need to feel that I am, I guess, dressed appropriately or not, depending on the case. Sometimes it might be romantic lighting. It might be music. It's a feeling that you are desired, that the person sees you as attractive. None of these things are related to age. Age only comes in when you look at the way the media defines sexuality. And all of a sudden you're then talking about, you know, do you have firm, perky boobs, and do you have muscles, and do you have wrinkles? All of these things are introduced by a media that has a huge investment in us paying a fortune to actually try and look young. If the reality was that we were only sexy according to the media's definition, then the bad news is we're going to become extinct, because no one's going to have sex, because very few of us at any age meet that Barbie doll, Barbie Ken criteria of what looks sexy. All of the things, I suspect, if you write down what makes you feel sexual or what attracts you to another person, are not birthday related. Yep, okay, we all like to look, you know, firm and so on, but that is not what defines whether we still feel sexual. It's all those other things that don't have an expiry date. Does it really matter if we're defined as asexual as we get older? Well, you've heard, yes. Sex is good for you. Good sex is good medicine. And I want you to just take it as given that when I talk about sex, I'm talking about consensual sex. I'm talking about good sex. I think some of these have been covered, but it's worth saying again that good sex decreases depression. Good sex reduces pain. It improves sleep, it increases self-esteem, it's fantastic exercise, it sustains and improves relationships, it boosts the immune system, and we sure need that as we're aging, and most importantly, it's good fun. So I want to ask all of you, it's a shame you're not all in the same room because it's a lot more fun then. Did you have sex this morning? Now, normally at this point, there's great shuffling and nobody quite knows what to do, because if you put your hand up, you might be embarrassed because no one else does. And if you keep it down, you're embarrassed. If you're under 30, you'll over-report. So you'll say, yeah, I had sex, because you don't want to admit no one wanted you to have sex with them. And if you're older, you tend not to put your hand up because it's embarrassing to admit that when you're old, you've had sex. Well, I'm here to say we've got to get over that. We've got to shout to everyone who will listen, and even those who don't want to listen, that yes, we have sex. We might be 70, 80, 90, 100, but hey, guess what? We're still having great sex, and we're probably having better sex than you 30-year-olds are having, because we've had years and years to learn about it. But older people get embarrassed, so we don't tell our kids we're having sex. In fact, my poor kid's probably the only one in the world who had to listen to me in a public gathering tell everyone that I have sex, and she buried her head. Kids don't want to know that their parents have sex. But if we're going to change the sexism around older people, then we have to stop hiding it. We've got to come out. We've got to make sure that our kids know that it's normal, it's healthy, we're still doing it, and you are not going to stop me when I get older. I'm in a nursing home or I've got dementia. It is my right to continue to be sexual so long as I'm not hurting anyone. GPs and nurses don't want to talk about sex, which was one of the reasons we developed the Sextat. They don't know how to raise it, they don't know how to talk about it, so it's not discussed. And as you've heard already, there are a lot of medications that are given to older people that impact your sexuality, but we're not told about them. We don't consent to it. We're simply, oh yes, this will be good for your blood pressure. And then, you know, a couple of months later, we discovered that the sex isn't working like it used to, and we've got no idea that it was actually the medication. In my view, no medication should be given without the person understanding the side effects. Doctors have got better at explaining the side effects of a prostatectomy. They're still not good at explaining the effects on your sexuality of a lot of the medications they give you. People in aged care are too often controlled by the staff and by their younger family members. Oh my God, you know, mum can't do that. She's being raped, she's being abused. Yes, there is some assault that goes on and it must be stopped. But there is also a lot of sexual activity that is asensual. The people involved are enjoying it. It's the staff who get embarrassed and uncomfortable and want to stop it. It's the children. Now, you ask your kids once they get past probably 12, but let's say 18, if they want their parents, they want you telling them who they can have sex with, and they'll say, absolutely not. You've got to turn that back on them and say, and you don't have the right to interfere in my sexual life. Provided I am appearing happy about what I'm doing, do not interfere. People with dementia have as much right as anyone else to continue to exercise and enjoy their sexuality. There was a great study done of people aged 80 to 102 some years back, so the figures would be higher now. 30% of females and 63% of males reported still having intercourse. 71% of females and 88% of males fantasized. 50% of females and 72% of males reported masturbating. Now, you've got to bear in mind that this is quite some years back where we were even less likely to admit we were being sexual, and that we are becoming better at actually admitting that we are sexual and talking about it. We're still not good, but we're getting better at it. And older people are not all pure. 14% of females were married, but 25% had regular sex partners, so they were naughty. And 29% of males were married, but 53% had regular sex partners. So we have to get over this notion that just because you've had X birthdays, that, you know, you're not having sex, or your partner's died, so you're not having sex. We can have sex for as long as we want to, and we can have it by ourselves, or we can have it with someone else. Let me just focus a little bit on people with dementia. People with dementia are not demented. They are people who happen to have a disease. And too often what we do is focus on the disease and forget the person. The person with dementia is still human. They still get hungry, thirsty, cold, hot. They still need to feel human, to be connected, to be touched, to be loved, and to be treated with dignity. Why would we assume they don't feel and act sexual? Why would we assume we have the right to remove that from them? There are many illnesses and treatments, as I've said, that have a negative impact. Arthritis, chronic pain, depression, incontinence, orthopedic surgery, hemorrhoids, hormonal changes, stroke, diabetes. We've talked about erectile dysfunction, dryness, lack of desire, drugs. But all of these things can be addressed. What are we personally doing to address it? Well, I'd like to say that we should think about how involved we are still in the mating or dating game. When you're younger, you put an awful lot of effort into how do I look? Am I fit? Am I being sexy? Am I looking desirable? But very often as we get older, we let these things go. And I just think it's really important that we continue to try and be as fit as we can be, to look the best that we can look, and to communicate. Communicate, communicate, communicate. Communicate with our partner, communicate with our family, and communicate with health professionals. I noticed on LinkedIn this morning, there was a new report came out from the UK. And one of the things they were suggesting is that either the doctor's surgery or the patient actually have a card that has on it, what do you want to discuss today? Because somebody somewhere has got to raise this ugly, scary topic of sex. And if you can actually write it down before you go in, then maybe the GP is more likely to put aside their embarrassment and talk about it. When I first started talking to older people about sex back in the 80s, a lot of ethics committees and others said, look, older people will not talk to you about sex. What I found, in fact, was they delighted. Nobody refused to talk to me. And it was because it was such a relief to be able to admit that sex was still important. So I think if your GP is embarrassed, shake him or her up and say, look, this is important to me and I want to talk about it. You take the first step if they don't. Write down some of the things that you want. There's no embarrassment. I think something over 50% of men over 47 have some erectile difficulties. It's so common, and we've got to be able to talk about it. We've got to be able to talk to staff, to doctors, but most importantly to each other. Just a couple of little scenarios I want to put to you. Jean has dementia. Her husband is very loving of her, but whenever he wants to take her home from the nursing home, she resists. And on her return, she's very upset. After some discussion, he says that yes, he makes love to her, but they've always had a great sex life and he can't understand her behaviour now and he's very hurt. How should people respond to that? Should they say, well, okay, you've always done it, it's always been great, just carry on? No, of course not. The husband needs to be counselled into understanding that she has now changed, she doesn't understand, and he has to accept that sex with his wife is no longer a consensual activity and it has to stop. Another one, again, in aged care, where an RN and a E and a complaining about Jack. They say he's disgusting. He speaks dirty to them. He touches their breasts when they do personal care and is often masturbating. How should one respond to this situation? Well, I'll tell you how I would respond. First of all, I would talk to the staff and say, keep your boobs out of his face if you don't want him to touch them. Careful of the language you use. If you say to someone with dementia, okay, Jack, let's go have a shower. Well, I ask you, how many of you have had a shower with someone, you're in the shower, without it having some sort of sexual touch? It's fairly unusual. So if you say to Jack, come on, let's have a shower together, of course, it's a natural reaction for him to reach out and want to touch. So we need to think about our language and the way we talk about normal activities that can turn sexual. Gertie and Bertie live in a nursing home. They both have dementia. They're found by staff in the woman's bed engaging in sexual activity. Should they be stopped? Well, if you know one of them have an STD, yes. If one of them is clearly upset, yes. But if both people are clearly enjoying themselves, then in my view, mind your own business and get out. You also need to look at whether or not it's sexual behaviour. Is the person with dementia bored? Are they ripping their clothes off because they're too hot? Because the clothes itch them? Do they need touch? Do they simply need massage? Are both people expressing yes or no? Are we expecting more consent than we would of others? Do we step in and stop young people from having sex because we think they had too much to drink? Not very often. So why are we assuming that we can step in and stop people with dementia? Are we being sexually abusive, either by neglecting a person's sexual needs? And here one might want to talk about whether or not it's appropriate to bring in sex workers. I know when I was in Victoria, there were a couple of places who specialised in meeting the sexual needs of people with disability. That may be not a personal choice, but we're not moral guardians of older people. We are there to ensure they're not abused, but not to be their moral guardian. We are not there to remove choice. It is not a matter of family first or staff first. That older person's rights, in my view, are what we need to look at. There are ethically challenging situations. Like I said, the husband having sex with his wife who has dementia and is clearly saying no. Health professional workers having sex with someone they're employed to care for? Absolutely no, that's a no-brainer. So I guess summing up, what I'd like to say is that we need to start shouting about sex, about the importance of it, regardless of our age. We need to make sure our families understand. And I think that, like advanced care planning, we need to say, yep, if I'm wanting to have sex and I'm assenting, don't interfere. Sex should be fun and good for us at any age. It should never be forced on anyone. And people living with dementia should still be enabled to enjoy their sexuality. So, I guess, well, I'm hoping that there will be lots of questions, but like I said, talk about it. Accept there's 100 different ways of enjoying your sexuality. Don't be embarrassed, or if you are, overcome it. Embarrassment won't kill you, and make your damn GP talk to you about it as well. Thank you.
Okay, Rhonda, we should have changed the name of this webinar. We shouldn't have said, let's talk about sex. We should have said, let's shout about sex. I really enjoyed your presentation. Thank you so much. And an important message that came out, which a lot of us suffer on a daily basis, is this whole issue of ageism. So, you know, your comments around that really valued by COTA New South Wales, and they're the things that we are trying to work, and it's like a really, really ongoing problem. And the other thing that I thought was really important from your presentation is this issue of people with chronic illnesses, people with dementia, that aged care providers are not the moral guardians of what the needs are of people in aged care facilities or receiving care in other ways. So thank you. Well, let's go across to questions. Just before I go to the questions, there was a couple of issues that have come through the Q&A session, and a lot of people are talking about medications and the issue of medications and the impact on their sexual life. And I just think it's important, everyone out there, if you've got problems around that or questions, I don't really think Jocelyn and Rhonda are the people to answer that, but just please make sure you do check with your GP about the interactions of drugs in your sexual life. I think that's the safest bit of advice that we can give. But on that, Rhonda or Jocelyn, do you have any comments about the issue of medications and people's sexual life? I mean, you did both bring that up in your presentation. So do you first, Jocelyn?
Look, I just think it's important that people also, you get a medication, you read what are the contraindications or what are the possible side effects. But I think it is just about being able to engage with your GP. And yes, as Rhonda said, there is a reluctance from a lot of GPs in talking about sexual issues. And I think the way to deal with that is just by being upfront and saying, particularly in regards to medication, are there any sexual side effects or any, side effects that I should be aware of?
And I think, as you said before too, it helps with the embarrassment if you can have a bit of fun. So make a joke of it, but still get your point across. I mean, I always find that if I'm a bit embarrassed, the best way out of it is to have fun, make a joke,
Yeah, and look,
the other person relaxes as well.
Exactly, but the reality is GPs are getting some training. I've done some training with GPs over the years on taking a sexual history, just bringing, giving your patient permission to bring it up. That, I'm comfortable in answering any questions that you might have, for instance, would be a way that a GP could open up about that. But, the reality is most of them won't just open up about it. If you've got some questions around sexual activity or then I think it's really important that you ask, are you comfortable for me to ask you about what's happening for me sexually? Or, being able to say, look, I've got issues around erections and I'd like to talk to you about it.
Yes, okay, that's a very good comment. I think this is an interesting comment from someone who's joined us this morning. This person is a community psychologist, and she's been working, he or she's been working that field for a number of years. And I'll just read it verbatim. Most clients were taking antipsychotic medication, which affected their sexual function. It was rare that a clinician during an assessment would ask about their sexual relationship with their partner when it possibly was the reason that they had not been taking their medication. I don't need either of you to comment on that, but I just thought that was a really interesting issue. This one I find this is very disturbing, and it's something that I think, Rhonda, now you talked about the issue of training staff, but this has come from one of our people on the webinar that says no policies on sex and sexuality until it becomes a problem. But either of you like to comment on that?
Look, I know for myself over the years, I've gone and spoken to aged care staff about sexuality, and you're right, it's a reactive as opposed to being proactive. So it's only when there's a problem that they start to think about, developing a policy around sexuality. And, let's be honest, a lot of staff in aged care facilities have come from other cultures. And I think that's really important to understand that for them, that talking about sex and, often, again, could be that, their religious practices are in conflict you know, what's happening within the aged care facility. I know I've been called out, and you know, for someone where there was inappropriate touching, and yeah, the discussion got round to does this person need to be visited by a sex worker? And you know, the organisation, the aged care facility, had to deal with that, and they were open to that as a possibility.
I think in our policy, what we did was to say, treated it a little bit like abortion, which is ridiculous, but still, that if the staff member had a moral reason that they simply could not engage in that conversation, that they shouldn't have to, but what they also couldn't do was ignore it. So they had to escalate it to their senior manager so somebody would have the conversation. So it protected the religious morals or whatever of the individual. And often it's the more junior staff that will first encounter the situation, and then not the people to have the conversation. It really should be the more senior person who often, if dementia is involved, will have the conversation with the staff member, with the person with dementia, and also with the family, so that everyone's on the same page.
Yeah.
Rhonda, while you've still got the floor there's another question that's come through about the recognition of same-sex relationships in aged care facilities, and that not being recognised or valued by staff. I think, to me, that's a huge issue. And don't we want, you know, as people get older in the last stages of their life, and if they have to go into an aged care facility with their partner, that those people are treated exactly the same way, with respect, being able to sleep together, doing all of those things that we've been talking about.
Absolutely. But I think it comes, I remember, again, going back to the 80s when the standards and so on were first being developed. And they had a government meeting in Brisbane, and I asked them why sexuality was not in any way addressed in the standards. And the fellows said, well, you know, if people are well enough to have a double bed, then they're too well to be in aged care. I think there is a bit of an attitude around whether it's same sex or different sex, there's still that view that it shouldn't be happening in aged care. And of course, if it's same sex, then that's even more mind-blowing. And there's a lot of work to be done too. And I think that there is insufficient work done on policy, so that when a person comes into aged care, be it to work or to live or to visit family, they understand the values of that aged care facility, so that you're saying up front, we value a person's sexuality, you know, we value same sex, we value all people. That's what person-centered means. You can't be person-centered just to this heterosexual white male. Person-centered means everybody. And that, I think, is not spelled out enough when people are seeking aged care accommodation.
I know that there is work.
Sorry, Jocelyn, go ahead.
There are people out there now who are actually developing programs and going into aged care facilities specifically for the LGBTIQ community.
Excellent.
It takes time. It takes time.
It takes time, that's right. Everything takes time. But the thing is, as we get older, we don't have as much time as we used to. It's very important that these things are acted on. There's another one that's come through, probably for you, Rhonda, because of your interest and work in the area of dementia. There's a couple of questions about the consent if the person doesn't have the capacity. How would you address that? I mean, give us some ideas around that.
Yeah, easy. My view is that from the moment a person wakes up in the morning, we assume assent. So whether it's to have a shower, to take their medication, to eat their breakfast, we know, is this person saying, yes, I want to do this, or no, I do not want to do it. So why do we treat sex differently? You know, we don't have a great debate about, is this person consenting to take their medications, or is this person consenting to have breakfast? We observe their non-verbal behaviour. Are they saying, yep, I'm enjoying this, or are they throwing it at you and saying, that's disgusting, I don't want it? I think people with dementia are far better able to let you know whether they're happy about something than people without dementia often, because some of those inhibitions are gone And so you get a very clear picture of, I don't want that, or I do want that. And my belief is that sex ought to be treated in exactly the same way as any other need. If the person is non-verbally saying, go away, no, then they are not assenting or consenting. And I believe that they can do that until a very late stage. Now, like if they're comatose, different story. But until a very late stage of dementia, a person can communicate to you whether they want something or they don't.
Okay, thanks for that. Jocelyn, in your practice, I know you're on sabbatical at the moment, but you've had years of experience in talking with established couples as they age and what their sexual needs are. How do you navigate when one person wants something very different from the other one? You know, their needs don't actually match. Tell us.
Well, you know, again, this comes down to consent, no matter what the activity is. And, you know, I mean, that's the most common presenting issue that sex therapists see, is what we call desire discrepancy. One person's wanting and the other's wanting less. And so, you know, it is, what can you do? You talk about it. You know, are they comfortable with this? If they're not, then it's not acceptable. It's not okay. You know, because you're married or in a long-term relationship doesn't give you the right to have sex whenever you choose to have sex.
Maybe I'm a Pollyanna, but isn't it also a bit like, if you've got good sex, then you want it. So if you don't want it, one needs to say, why don't you want it? Why is the sex not good?
Yeah, exactly. I mean, one of the things we do know that is, you know, which is really goes against sort of the humor around women never wanting sex, is that with older couples, when sex actually stops happening, it's usually because of the male, and it's usually related to erectile function. But of course, the awkwardness about communicating that. So when sex stops, for many women, you know, and because couples struggle to talk openly about it, they take it on that, you know, that it's about them. Yeah. You know, they question their attractiveness, or whether, you know, what have they done wrong? When in fact, you know, it's usually related to erectile function, because men have been socialized that it's all about, you know, the penis and having a hard on, and again, you know, all about penetration. So, you know, whereas we make humor about my wife never wanting sex, you know, in fact, the stats show something very different.
Yeah.
So I hope that answers that.
Yeah, thank you. I thought the stats that you presented, Rhonda, were amazing. the ones, you know, for that group between 80 and, what was it, 102.
Yeah, and, but bear in mind, like I said, that's very old, and people are more embarrassed.
Right.
So the figures nowadays are even higher.
I think one of the things I'd like to also talk about is the use of pornography.
Sure, go ahead. I was going to, just before you do, I was thinking, you know, thinking about things that excite me. And one of the things that really excites me is music, especially music by Black people. And so my favourite guitarist is George Benson. And guess what? He's coming to Sydney. And guess what? I've got a ticket, and brings back all sorts of memories of seeing this amazing guitarist over the years. And I just know when I go, the age group will be my age group, you know, because women have been so excited, and men, by his like, he's a very, very sexy man, and he's a brilliant guitarist. So anyway, sorry, I shouldn't have gone.
Now I've forgotten what I was. Oh yes,
pornography. Yeah, George Benson's not pornography, but yes, go ahead.
No, but it's lovely eye candy. But I think, you know, I've seen a lot of people over time who come present with my partner or I have a porn addiction. So first of all, I'd like to say it is not an addiction, because normally with addictions, there is some physiological response with withdrawal, and nothing happens to somebody when they stop watching porn. But I also want to normalize the use of you know, using soft porn or feminist porn. You know, some people are particularly visual, but what we are seeing, particularly with younger guys, is delayed ejaculation, inability to ejaculate. And every time when I inquire about their masturbatory habits and their use of pornography, that normally raises its head, so to speak. So, you know, what happens for a lot of men is, yes, men, I think, generally are more visual than women. I'm probably putting my neck out, getting myself in trouble here, but I think that is the case. And I think what's happened to a lot of men is they've become lazy. They've got used to a high level of visual stimulation that not one person is going to be able to meet. So what I say to men is, you've got lazy. You know, you're relying on external stimulation when in fact your brain is your greatest sexual organ, and your ability to create that fantasy or whatever it is you need to do. You know, the reality is it doesn't translate well into a couple relationship, because you know, that if a couple chooses to watch porn together as a way of getting some sort of interest and desire and arousal, great. You know, for men who access porn every now and then, great. But for people who rely on the use of pornography, they're actually doing themselves a disservice.
That makes
And
sense.
I'm not anti-porn. Porn's going nowhere. But there, you know, yes, like everything else, if it's on occasions, great.
Mm-hmm. Interesting, very interesting. There's a couple of questions I thought we could perhaps, we're getting to the, oh no, we've still got quarter of an hour. Exciting, we can keep talking, excellent. The issue of menopause, and I'm not sure who would like to answer this, but it obviously does affect women's sexual health. And I guess the two questions, what can be done about that, but and also, are there sexual changes for men? You know, do men go through similar issues? Yeah.
Well, I think we need to first of all normalise that men will have erectile difficulties at different times. I think that you know, testosterone levels need to be checked, particularly if they're having some difficulties. So a proper medical checkup is important. For women, of course, we know that with the decrease of estrogen, that affects the tissues of the vulva, the vagina become thin, and that's often the cause of pain. So what's important is, first of all, you know, to start using a really good lubricant. And there are now laser treatments for women who are experiencing different problems with vaginal tissues as they age. But, you know, yeah, menopause, of course, does have, you know, does have an impact. Everyone's different, but yeah, I think it's something that you absolutely should be talking to your GP. If you're not confident with that, get a referral to a good gynecologist.
I think also some of it is, and I'm not basing this on research, you'd know this stuff better than me, but I think some of what we call menopause is also that collision with the fact that we might have stopped putting as much effort into the relationship, we might be bored, blah, blah, and all of those things are coalescing at around about that sort of 45, 50 age. And too often we blame it on menopause when, like you say, it could be laziness. We haven't put the effort and communication in to keep arousal and a good relationship going and the juices running.
Well, yeah, exactly. And I think the other thing for people to realise, and I'm not suggesting that it's all men or all women, but basically for women to want to be sexual, to lean in or to initiate, they need to feel emotionally connected in order to be sexual. For men, however, and I'm not talking all men, generally speaking, it's through being sexual that they feel that emotional connection. So you've got two people coming at it from different perspectives. And I think it's worth, you know, understanding that. But of course, it makes perfect sense, though, that emotional connection and looking at the relationship and how they put in time is really important. I think also the other thing I just wanted to briefly mention was about the 5 love languages that probably most of you have heard of. 5 ways that we feel loved have been identified. One of them is through touch, which is sex, holding hands, you know, whatever that looks like. One of them's words of affirmation. So, you know, hearing compliments and nice things said. Another one is acts of service, the doing things. So making a cup of tea, cooking a meal, mowing the lawn. Another one is gifts. So whether that's a chocolate frog or a diamond ring or a book or whatever.
Can I choose?
And the last one is time. So putting in time with your partner. So helping, you know, and it's very easy to work out what your love language is. And it's important for couples to do this. You can just Google 5 love languages and questions will come up to help you identify. So it's important to know not only how you feel loved, but equally so, how does your partner feel loved? And using, because often how we express love is how we feel loved ourselves. So, you know, people can be missing each other completely.
What's it called again? 5 love languages.
5 love languages.
5 love languages. Okay, that's very interesting. Simple in a way, isn't it?
Yes.
Yeah,
I'm greedy. I want all of them.
But some are, and that makes it easy. But very often couples don't. Might be for one person that it's about time, and the other one's it's about touch. So for most men, I will be honest, touch is one of their primary love languages. And so, you know, it's very easy to be hurt and to feel rejected when sexual intimacy is not on the table.
There's been a few questions that have come through, which you probably have seen, Jocelyn and Rhonda, if you're just sort of tracking through the Q&As about having more than one sexual partner. There's some things that have come in around that.
Mm-hmm.
Not sure what sort of comment you want to make about that, but also people who have lost partners through death and or separation, divorce, about wanting to have casual sex and what would be, you know, the safest way, I suppose.
There's certainly with all the different online dating sites now, and I've checked out a few of them, just, you know, from a professional perspective, there's everything you can find on there. So if someone's just wanting a friend with benefits, or they decide to open their relationship, what's important about opening your relationship is it's based on trust and honesty. It's not about secrets, because that will only potentially cause damage. But yes, you know, there are many couples, relationships take so many different forms nowadays. And yeah.
But I think it also comes back to your 5 languages. I mean, I think it would be often very difficult to be able to negotiate that pathway, leave aside diseases, but just most of us want that very special connection. And I think it's hard to keep that special connection if you're then going to have lots of others as well.
Oh, absolutely. But, you know, in my practice, I've only seen couples where this is the problem, and that's what they present with. So you look, it's not easy to have open relationships or polyamory, which just means having, you know, intimate relationships with numerous people. I've only ever seen those that haven't worked. Many couples, you know, think outside the square and think about, you know, going to a swingers party or doing different things. I think some people navigate it well. I think most have a struggle.
Thank you. Let me just have a look and see. We're getting towards the end. Oh no, I think we've sort of answered that. You know, there is.
Someone's just put up here about, I believe you have to raise the issues with sex and different cultures and religions such as Islam with prohibited masturbation. Yes, I think that, you know, we have to, you know, as a sex therapist, you have to respect whatever cultural, religious beliefs somebody comes with. That doesn't mean that I change my stance on seeing masturbation as a healthy activity. It's a choice that people make.
And I go back to, if I'm looking at aged care, it is I can't impose, if I'm a nurse and my religious thing says masturbation's bad, I cannot impose that on a resident.
No, absolutely.
Nobody can make me go masturbate. That's my value, that's my religion, but I don't have the right to then impose that on someone in my care.
Absolutely. I think that also, Rhonda, brings up another point there that I think aged care staff need to be more aware of. You know, just because someone's on their own, you know, barging into their room, their space of privacy, is really important, that they knock and that they check. And, you know, Yeah, as opposed to making someone feel awkward or that
And
they're
some
doing
older people are very innovative. Like, you know, if they can't find a vibrator, they'll find a candlestick.
exactly. Yeah.
Well, I tell you what, folks, I have heard both of you speak before, and I've still learnt more and more. It's just been absolutely. I know it's been incredible because you know why? I think your honesty and your experience really shines through, and there's such key messages that we've all heard. And I was go back to that one that Rhonda you talked about the moral guardians, and you know that often happens not just within aged care facilities but amongst family as well. And
Yeah.
our rights are as important as we eat every day. Our sexual rights are the same basic needs that we all need to satisfy in whatever way. And Jocelyn, I'm going to look up those 5 love languages. I think that's some really practical things that all of us can have a look at and see what sorts of things suit ourselves and suit our partners. But I do think we do come to the end now, and thank you everyone out there. We've had some really interesting questions that have come through, and we've had lots of people come back to say it's been very informative, well conducted, and fantastic information from both our speakers. So thank you very, very much.
Pleasure.
It was terrific.
Great
Okay.
fun. Thank you again.
No, terrific. We won't be giving up on this subject. And then I said the next one we'll call Let's Shout. Let's shout about things.
Joan, if I could just add that, you know,
Please do.
one of the things with going to your GP, if you sense that your GP is not comfortable in talking about it, then you ask them to refer you. Now, you know, the reality is that most relationship counsellors do not talk about sex. If you've got a specific sexual issue, then you're much better off by seeing a psychosexual therapist. Most of us are trained in couples therapy as well. And the Society of Australian Sexologists is the go-to place.
Great. Yes, thank you very much, Jocelyn. That's important. And also, Rhonda gave us some good hints about if you do have a good relationship with your GP or your health provider, it is important to write things down, I think, because often, you know, going in, people get very uneasy. There's a bit of a power struggle sometimes. And I think writing things down is really important. And then I think, Rhonda, you said if you don't feel like to actually verbalise this, you could show a note to your GP and say, this is what I want to talk about. I think
And
that's
use humour.
Use humour. Yes, I can. I'm always using humour. It's the only way to get through every day, I say. All right, folks, thank you very much. Stay with us. Just as I finish today, I would like to again thank Rhonda and Jocelyn. I think it was just terrific. And we'll be running these webinars all through this year, and ones that come up as being very popular, we then like to repeat them because a lot of people don't get to see them. They may not be comfortable watching on YouTube. And the important thing is it's a conversation that needs to be, we need to keep it going. We just can't have them, you know, conversation, webinar, one-off. So folks, the next one that we've got, let me just have a look. Oh yes, the next webinar is about the do's and don'ts of downsizing. And I've started. And I'll probably learn a lot more, but the important thing is we've got a guy called Peter Walsh, and he's the host of Channel 9's thing called Space Invaders. I haven't watched it yet, but I will have a look at that. So Peter's going to join other panelists, and we're going to talk about the do's and don'ts of downsizing, which I think it's an important practical webinar that I'm really looking forward to. Now, don't forget, folks, that I told you about community speakers. We have those people available to come and chat to you about a range of topics. Check our website, or you can give us a call on 9286 3860. That's 9286 3860. So let me have a look at the time. It's 2 minutes to noon. And so I wish you all a very, very happy morning. Think about all of the things that Jocelyn and Jocelyn and Rhonda have shared with us today. Think about putting some of those things in action. I think is really important. Don't just see it as information. See it as a way that we can actually apply some of this knowledge to better our sexual health and therefore our overall health and well-being. Please stay safe, everyone.
And the technology worked.
And the technology worked. I know, it's terrific. I'm very pleased about that. But importantly, our world is going through some difficult moments, and COTA New South Wales is with all our people that have been flood affected, especially our older people and their families. We've been through so much in the last 2 years, fires, the COVID, now floods. But guess what? We're all here together, and staying connected is even more important during these times. So be safe, folks, and I look forward to seeing you at the next webinar. Bye for now.
Bye.